Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, this is a topic you know a ton about, isn't it?
It's one I always have questions about, but I think we've had, last count, this is our 37th episode on high blood pressure, if I'm not mistaken.
Yeah, Paul, the audience can't get enough of it. Turns out, kind of neither can I. I love talking about high blood pressure, and this was with a great guest, Dr. Jordy Cohen. She's a hypertension expert and a nephrologist. And Paul, to start us off, what are we doing with blood pressure cuffs these days? Those manual ones on the wall, those are the way to go, right?
Yeah, so this is a scenario that we talk about all the time, and I think we've beaten this drum a lot in prior episodes. But I think we've all experienced someone whose initial triage high blood pressure reading is elevated, and so the patient will ask for a recheck, or you'll ask for a recheck, and then you're tempted to use the one that's been hanging on the wall that has not been calibrated in 17 years, where the little sort of spirally cord is kind of decaying and looks like it would fall apart if you touched it. Turns out that's probably not the best way to do it, Matt. So it's just to reiterate, the automated cuffs are the preferred way. They are more accurate. The days of mercury thermometers are long gone for environmental concerns. So we're using the automated cuffs now, making sure that we use the appropriate cuff size. And we even talked in this episode, we do have patients sometimes that have large arms or conical arms. And every so often you have to use a wrist measurement. But if you're doing that, still positioning matters. Feet flat, back supported, not on the exam table, certainly not lying down weirdly. And if you're going to do it on the wrist, make sure that you have the elbow resting on a table, and then you actually have two fingers on the opposite clavicle so that everything is kind of at heart level where you need it to be when you're measuring it. And if it's around the arm itself, again, the arm resting on a tabletop or bedside, or even your own arm, just so that it's at heart level.
Yeah.
And not talking, and just giving the patient every chance to have an accurate blood pressure reading. That's the first thing when you're diagnosing high blood pressure, and then everything else kind of follows that. You should only treat a diagnosis that you've appropriately made. And that's the point that we sort of started out the episode with.
All the goals are based on a properly taken blood pressure. So if you haven't had a properly taken blood pressure, you might over or under treat somebody. So, but if you do confirm someone has high blood pressure, for most patients now who are non-frail, we're shooting for less than 130/80. The KDICO guidelines for patients with chronic kidney disease say less than 120/80, which is very hard to do. So if we're getting people with a systolic in the 120s, that's probably about as good as we're going to do. Dr. Cohen and I have adopted this practice since we started hanging out with her a couple years ago, at least virtually hanging out with her, Paul. And the combination pills, so either a calcium channel blocker with an ACE or an ARB. I usually prefer calcium channel blocker with an ARB, or the triple pill with a calcium channel blocker, an ARB, and a diuretic. That's what I go to now as my first line agent. I'm using a lot of either low dose combination or medium dose combination. I usually don't go to the highest dose unless I'm between starting a fourth med and going to a higher dose. So that's really been a practice change for me. And she reiterated tonight that she just thinks that's the best way to go. It's easiest for the patient and usually less side effects when you do that low to moderate dose in combination.
Yeah, it's a point that we've made again in prior episodes, that as you sort of maximize these medications, you get diminishing returns in terms of blood pressure efficacy, but you get increased side effects with those medications.
Yeah.
So you're far better to add on something at kind of the median dose as opposed to really trying to crank up the doses of the stuff that you have, because you just don't get that much more benefit from that.
So Paul, we're going to talk about some of the newer agents and just run through them. Now, this first one I want to ask you about, it's not quite a blood pressure medication, but it has blood pressure lowering effects. So what am I talking about here?
That's my favorite game. Guess what I'm thinking? But I think you're probably referring to semaglutide, Matt, which I think we all have a fair amount of comfort with for a weight loss medication or for a diabetes medication. And the indications keep piling on, which is great. I mean, these are remarkable medications in general, this class of the GLP-1 agonists. But semaglutide in particular is not approved for hypertension, but it does cause blood pressure lowering. And that tends to kind of ride along with the weight loss that you see with it. So it's not technically an antihypertensive, but you see some great blood pressure benefit when you actually see the other benefits that come along with this as a medication. But I think there's also some fancier pants stuff coming down the pipeline that we should probably be aware of, right?
Yeah. So the first one I'm going to mention, as a generalist, you're probably not going to be prescribing this, but the endothelin receptor antagonists are out there. They're probably going to be prescribed by hypertension specialists. And they have a modest, compared to placebo, about 4 millimeter mercury blood pressure lowering, but they are approved, so they're out there. But what's more exciting, Paul, are these aldosterone synthase inhibitors. And the generic names for those would be something like baxdrostat, lorundrostat, and they're not yet approved, but they're in, I believe, phase 2 or phase 3 trials, depending on the indications they're looking at. And they seem promising. They have much more of a blood pressure lowering. I think we said maybe 10 to 15 millimeters blood pressure lowering, and compared to placebo. So these were significant. And Dr. Cohen thinks that, these are probably going to be in the primary care wheelhouse, like that. Once, cost will probably be an issue, but otherwise these are pills. They're taken once a day, and probably we will be prescribing these at some point. So pretty exciting to have these. And they don't have the sort of the androgenic, anti-androgen side effects that you get with the mineralocorticoid receptor antagonists like spironolactone. So that's what she was really excited about.
Yeah, and the MRAs, traditionally sort of your fourth line medications, unless you have compelling indication. So to have something else in your armamentarium to pull out that has less side effects is
Right.
super exciting. So yeah, it'll be great to see these in the pipeline.
What would you say, Paul, if I told you there was a medication for blood pressure that you gave once every 6 months, and it's going to just shut down the renin-angiotensin-aldosterone system? How does that sound,
Yeah.
Paul?
To me, as someone who's taken medical school physiology, it sounds lightly terrifying. It feels like you do need that for some things, but I think for people that are less interested in taking medications, which is a lot, most patients, but if for someone who wants something that they take one time and control their blood pressure, it could be potentially as exciting. And I think as long as we have a way to kind of reverse the effects of it, which I think was one of the sticking points, if we
Yep.
need to, then I think there's potential for excitement around this medication.
So I'm of course talking about a small interfering RNA, and this is the one that we talked about was zilebesiran, and it's a small interfering RNA, and it's going to be given once every 6 months. But no one would feel comfortable giving this unless there's an antidote, because if someone gets septic, they probably need their RAS system
Yeah.
to help them out there. So
or pregnant, or lots of
yeah,
reasons why you might actually want that working.
exactly. Now, some people just don't want to take medications, even if they need them, Paul. So what else might be offered to a patient with high blood pressure, and how excited should we be about this therapy?
Yeah, I feel like you're asking the wrong guy, Matt. I think you're alluding to renal denervation therapy, which I feel like has had a lot of initial wild enthusiasm, and then it kind of waned, and now I feel like enthusiasm is it's back, baby. We're back into renal denervation. It sounds great because I think we're doing a little bit better job of it, but the effect you get of blood pressure lowering is about the effect that you'd see of a single agent medication. So realistically, these patients may still be on medications for blood pressure control. And it's only effective for about 2/3 of people who get the procedure. So that's 33% of your patients who would go through this invasive procedure where we're frying a nerve, and then they may not actually have efficacy from it. So I think there's a population that would benefit and be interested in it, but I think it's not something that we're going to be starting for first line for lots of folks, just because there is the potential for treatment failure, and you still need medications for probably most of these patients at the end of the day anyway. But still exciting that there's evidence for it. It does cause significant blood pressure lowering, so it's nice to have another option.
Yeah, and I think people are going to be coming and asking about it. So knowing a little bit about it is important. If you want to hear an in-depth discussion about all these things, plus how to work up resistant hypertension, then check out the episode. You can click on the link in the description below. And Paul, I guess that I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yeah, I don't, for some reason, the way you said brain hole this time around, maybe even more uncomfortable than usual, but I remain Dr. Paul Nelson Williams. Thank you, and goodbye.